Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform.
You go.
Hi, welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel. Hi.
So we're going to do best of ASCO : 2026. And we thought we would start with the uveal data that Milena Orloff presented. But before that, I think you thought you were going to ask me a icebreaker type question.
Yeah, I have a quick fire for you. Which meeting is bigger, ASCO or ESMO?
Well, that depends how you measure size. Do you mean number of people that go to it?
Registrants, maybe?
I don't know, is the answer to that. Are these figures easy to come by in the public domain?
Yeah.
Are they?
Yeah.
You must know the answer, otherwise you wouldn't have asked me.
Well, I think it's something like 40,000 for ASCO and 36,000 for ESMO, something like that.
Oh, so quite close.
Let's fact check that. And then how many, did you have a sense this year of how many NEJM publications were concomitant with ASCO?
No, but it was a few, to say the least.
You could probably name one at least, right?
The pancreas one, definitely.
Do you know how to say that drug name?
Not very well, do you?
Daraxonrasib.
That sounds pretty good. What, have you been practicing, have you?
I have.
Yeah, that's cheating. I think there were at least a couple of others, I must admit. Maybe something in lung cancer, I think, but yeah, or maybe one or two things in lung cancer.
I honestly don't know. I didn't get a good sense for NEJM concomitant this year. Because, ESMO feels like it's boom, 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 NEJM, Niagara, Keynote 522. And it just, but I didn't know, I don't know if I got a good sense of it from that this year. So definitely daraxonrasib. We'll definitely fact check how many came out concomitant. It's probably right now sitting on the NEJM website, but I didn't want you to cheat, so I didn't give you a heads up. Don't you dare. No, I know. And then last question, do you know the mechanism of action of this daraxonrasib?
Yeah, it's called a KRAS on inhibitor. That's all I know about it.
So I learned this from going to that last thing on Monday night. The real benefit to that, it was like disease groups gave their kind of top 3 to 5 to 6 presentations of the meeting. So it was really good for, like a simplest like me who only practices basically one tumor type, one disease type. You kind of got to hear it from everybody. So what I heard from the GI group is that most of the RAS inhibitors that have been developed so far target the mutant RAS form, of course, but it's RAS in its off form. And most of RAS exists in its on form. And this is kind of a molecular glue. The drug glues KRAS in its on form, which is its most common, i.e. active form in these cancers, and then basically sterically inhibits it. So now KRAS in its on form cannot go on and do its normal oncologic signaling and binding because it's been glued up. That's sort of my understanding.
At the risk of another fact check before you've even started, do you know if in principle that could work for other RAS alterations apart from KRAS, NRAS being the one that would be of interest to us?
Yeah, so that's the point, is to date when we've been developing these, have they been all developed for the off state, but actually this, gene/protein exists in the on state. And so if you are targeting KRAS in the off state, you're probably targeting 10% of KRAS in these tumors. And so can you just make glues that will bind the sterically on site of RAS, whether it's KRAS, HRAS, NRAS, in these tumors? And then, the other part of it is if you want to follow along how the drug and disease are doing, do you have a high shed rate from that RAS mutation, from that RAS tumor into the periphery so that you can follow along? And my understanding in pancreas cancer is you actually don't have a high shed rate. And so how valuable is looking for that ctDNA, despite knowing exactly what it's doing? It may not be as directly a surrogate. But anyway, yeah, so it's a possible strategy for other, I imagine, that's what Revolution Medicine and all these other companies that have these good RAS formulations are thinking.
But it's a real milestone, isn't it? We should say
Yeah,
that.
yeah.
A real milestone.
I mean, RAS has now been druggable with sotorasib. To get this in pancreas cancer, and there's several videos now online of when Brian Wolpin from Dana-Farber was presenting, and the Kaplan-Meier curves show up. And it's not as if they're the most dramatic Kaplan-Meiers that we've even ever seen in oncology, but in this disease, where the last, I don't know if it was an NEJM or Panc or JCO publication here, I just led to another fact check. Gefitinib, erlotinib, Tarceva in pancreas cancer, it had an approval in the US, but not in the UK, if I recall correctly. And it had an OS benefit of under 2 weeks. But that was a major advancement, is to improve survival for, God bless, 2 weeks in this disease. And now the OS was getting pushed out to, I don't know, a year or so. So big deal. But when Brian shows those curves, the room erupts in a standing ovation. And it goes on for, a minute, 2 minutes or so. And he actually said then after, he said, I didn't allot for that in my time. He didn't allot for the disruption by standing ovation. It's very sweet. So big deal for this disease,
I think we can allow, can't we, going over a minute or two for a landmark development in a very difficult to treat cancer.
Yeah.
And I think, well, no, I was going to say one more thing. I mean, that's metastatic, right? But it's pretty interesting, isn't it? Obvious questions about locally advanced disease and kind of getting people into a situation where they might be operable if they hadn't been in the past. So it really opens up all sorts of interesting possibilities, which I guess people are going to be looking at over the next few years.
And you bring up a good point. I mean, neoadjuvant or perioperative in pancreas cancer is a thing. I mean, they are using. So now thinking about using it there, and then what would that maybe even do for de-escalation of these big surgeries that we know often accompany resectable pancreas cancer? Huge. So maybe that's a nice transition. I mean, another one of these kind of landmark events would be for uveal melanoma. We've never had a targeted therapy that we've known could really affect meaningful efficacy. And we have these mutations that are kind of upstream of RAS. They're G protein coupled receptor mutations, so GNAQ, GNA11. They're even more upstream of RAS, but they do signal down the RAF MAP kinase pathway, in addition to protein kinase C signaling. So G protein coupled receptor mutations essentially will also activate protein kinase C pathways. And so the first abstract we're going to discuss is this Optimum O2, as you said, presented by Marlena Orloff, global phase 2B portion of a study that also has a phase 3 component. And this is first-line treatment of metastatic uveal melanoma, HLA-A0201 negative. It's darovasertib, protein kinase C inhibitor, plus crizotinib, which is a multi-kinase inhibitor. In this case, we think we're exploiting c-MET inhibition. This was randomized against investigator's choice, which in this study was essentially checkpoint inhibitor or chemotherapy. The phase 2 component that we heard about had a primary endpoint of progression-free survival by BICR, blind independent central review, and then a secondary of investigator-initiated PFS. Ultimately, this data is what we think the company might be using to then go for accelerated approval, and then they will use the phase 3 OS as the sort of confirmatory data. So phase 3 is enrolled, but basically the readout for that, the OS endpoint, has not been uncovered for this analysis, so it remains blind, and we will see that at a later date. What did you think about the data? Did you think anything about maybe dosing, demographics? Anything jump out at you?
Yeah, I mean, just the background was interesting actually, because this isn't the first protein kinase C inhibitor to come along in this disease. We were just talking about that. And so we were involved quite a while ago with a trial of AEB071. I think that was a Novartis drug at the time, in combination with a MEK inhibitor, which actually, in terms of combining these two drugs, wasn't very easy. And actually, there wasn't really any efficacy, and that paper came out about 3 years ago. So I think quite an important point here was that the biology was always strong here. And I guess what we're seeing here is actually a good drug to hit the target well. So that's a sort of important lesson. Almost goes back to the early days with the whole business about sorafenib as a BRAF inhibitor, without going off on that tangent,
Yeah.
So that's maybe something important. No, I mean, I thought the data were great. I mean, maybe just to talk about the dose, because I guess I'm a bit obsessed about this. And whenever I see a trial like this, I sort of think to myself, well, what doses have been given of the two drugs in combination, and how does that relate to the single agent doses? Go on.
Because one of the things you brought up, I mean, you asked a very reasonable question. How do I know what's doing what? What's the contribution of drug A and drug B, and what was the single agent activity, and what percentage of those drugs are we using here? And to be honest with you, I was a little data blind to it. I hadn't really remembered because, it's been a while since we've seen the single agent for crizotinib, for example, and the
Yeah.
single agent darovasertib data.
Yeah, so maybe just to talk about that now. So for crizotinib, which has now been around for a while, and there's a few different labels, the normal dose is 250 milligrams orally twice a day. And then in this study, basically the dose was 200 milligrams orally twice a day. So that's 80% of the crizotinib single agent dose, without sort of getting into a conversation about what the MTD is or anything else, but it's about 80%. So I would say, just from the first principles of combining targeted drugs, that's fairly respectable, if I could use that formulation to say something's fairly respectable. And the darovasertib, again, if we look at the single agent dose, the phase 1, actually, I was just looking this up, was in BJC not too long ago. Quite a few different doses were tested, and they landed up on 300 milligrams also twice daily. Again, you might have been able to give a little bit more. So in this trial, I'm just looking at the schema here, that's actually the dose I think that they elected to go with, if I'm not mistaken. So probably pretty close to what you're able to give as a single agent. Go on.
Well, I mean, what I don't recall from that single agent paper is, if the MTD was, did you say the MTD was 400 twice a day? The RDE was 300 twice a day. Was the RDE chosen because they knew they were going to combine it?
I'm
Because
not sure.
efficacy wise, right, exactly. Efficacy wise, as a single agent, we thought already we had hesitations about developing as a single agent. So the RDE was, so in other words, it's exactly the 300 twice a day, but in truth, is that under the MTD of a single agent, which I think it is.
Yeah, I mean, I'm just reading actually from the phase 1 paper. I'll say the citation in a minute. But there was one DLT of grade 3 hypotension treated at the highest BID or BD in British terminology dose, which was 400 milligrams twice a day, to be really clear. So yeah, it may well be that some more could be given. Let me just give you the citation of this. So this is BJC January 2023, and Sophie Piperno-Neumann is the lead author of that. So it's worth having a little look at that. And it was called LXS 196 at the time as well. So anyway, so it still gets back to the question though, doesn't it? So that's a bit of sort of spiel about the drug dosing in comparison with the single agent doses. Let's just say, for the sake of example, they're both at least 80%. Again, same comment from me. That's respectable. So do we know, if you're just given the darovasertib, what type of efficacy you may have seen as a single agent at those doses? So again, I'm putting you on the spot a bit, aren't I? I'm moving out of the centre as well. Is that what that hand gesture meant?
My hand gesture was, wouldn't it be in that citation you just mentioned? Wouldn't the efficacy of monotherapy be in that citation?
No, because it was a phase 1, and there were loads of different doses. So I mean, I was thinking about the neoadjuvant, and I know that's a completely different setting, obviously, but I guess it gives some sort of handle on single agent efficacy. I mean, and the reason to debate this, before you answer, is of course that, you know, you know more about this than I do. The trial protocol was obviously mandated that dose reductions be done in a certain way. And then, assuming that this is approved, this combination, which seems fairly likely, and hopefully we have access to it, we'll actually have to figure this out in clinic. How do we do our dose reductions?
That's totally the great segue. I mean, the truth is, so which drug is doing the efficacy, which drug is doing the toxicity? Just like if you're using BRAF/MEK inhibitors, you might hold both drugs. You might hold the drug that you think specifically is responsible and continue the other one going. In a way, you might say that the same thing happens with ipi/nivo, when a tox happens. In general, though, we hold both and wait for tox to recover before we maybe introduce one or both drugs. With targeted therapy, it's not that uncommon to keep a drug going while a tox is happening that you think is specific to the other. So what you're saying is absolutely right. In the real world, separating out the efficacy and the toxicity will be important. Will the neoadjuvant setting, i.e. intact tumor in the eyeball, help drill down where we're only using daro monotherapy? Will that help us drill down on the real efficacy of daro mono? I'm not certain, because does efficacy in a choroid restricted space equate to efficacy in a hematogenously spread metastatic lesion? I don't know, I guess is the answer. That being said, maybe we should talk about efficacy. Do you have the efficacy slides?
Yeah, we can. I mean,
PFS, and then we go to response. Yeah.
Yeah. I mean, one interesting question, obviously, is whether regulators will take a view on what we've discussed or not, but maybe let's not dwell on that too much now. Yeah, so just cut straight to the chase. Primary endpoint, progression-free survival, hazard ratio 0.42 in BICR, and then investigator assessed 0.36. That's quite a high level of concurrence, I would say. So at the end of the day, really.
I'm trying to get my camera to do that. Sometimes it's so finicky when it does it. I don't know how to get the fireworks to go off, but that's tremendous for a disease like uveal. Can we just admit that a hazard ratio of 0.4?
Hazard ratio 0.4. Yeah, I mean, and it's worth just saying, I know we mentioned the control arm, a bit of it. I think 3/4 of the control arm was ipi/nivo, so that is a respectable control arm as well. I think in this disease, you can't really argue with that. Go on.
And did we even say numbers enrolled? Like, what was let me look back at the demographics.
Yeah, 210 for D plus C, if we're going to call it that, and 103 for the investigator's choice. We haven't really said too much about baseline characteristics. I don't know, you're the expert on this disease.
Yeah, they're fine. They're fine. But the ipi/nivo being 3/4, it humbles me, and we have to now say that this is an adequate and an appropriate randomized ipi/nivo data set, right? So as much as we might want to look at our single arm phase 2 non-randomized trials of ipi/nivo, the Spanish and the US trials, this is really the new benchmark for PFS, objective response rate. It's going to be hard for us to convince everybody else that treats this disease that you can get double-digit response rates to ipi/nivo when we couldn't get it in this trial. But the PFS is right there for us to see. The blinded independent central review, the PFS is more than doubled, hence the hazard ratio of 0.42. So a control PFS of 3.1 and median, and in the daro criz arm, it's 6.9 months. Great to see that kind of PFS. We think that should undoubtedly translate to an OS benefit, but of course, let's see. The next thing we all think about is, well, how much did it shrink tumors? What was the objective response rate? So there's some nice waterfall plots there of blind, independent, and investigator initiated, very reminiscent of our BRAF MEK days, where the inflection point is all the way to the left of the graph with the interventional experimental arm. But an objective response rate here, numerically was in the 30, what are we calling that? 30?
High 30s, so 37 odd percent in BICA, 39% investigator assessed. Worth saying though that, and I think we said this when we first saw the data, investigator's choice may be slightly on the low side there, 5.8 and 1.9 respectively. And while I'm talking, I'll just say something about duration of response, 6.8 months actually, depending on how you assessed it. So sort of, you'd say, behaving like a targeted therapy, perhaps in terms of duration of response. And again, I don't think either you or I could understand why there wasn't a duration of response quoted for investigator's choice, but that's a sort of minor thing, I guess.
Yeah. Also, interesting to note that the investigators missed 5 complete responses that the blind independent central reviewers picked up. So 5 patients on the experimental arm had a complete response, unless I'm reading this table incorrectly, that the investigators did not assess. Probably those were some lymph node variants there. You know, we forget that when a lymph node gets down to kind of 1 centimeter short axis, we're allowed to call it 0 on a RECIST form. Maybe that's what it is. I doubt it's liver mets that investigators thought they were still measuring, that the blind independent said, no, those are gone. But anyway, that's kind of interesting. So all told, you know, the efficacy looks real here, but now we got to get to toxicity, because that's not a minor point here.
Yeah, and I've just got the toxicity summary slide up here. So treatment-related AEs, grade 3 or 4, about 40%, investigator's choice 37%, and there was 1 death in each arm. And then they've got this complex bit at the bottom of the table, leading to one of the drugs being withdrawn or dose reduced, etc., etc., etc. So, you know, you'd have to say that's not a minor level, or I would say that's not a minor level of toxicity, one comment. Second comment, very difficult, I think, to compare side effects from targeted therapy with checkpoint inhibitors, obviously, because diarrhea is the obvious one. I mean, those are really very different entities, for example. But again, I think it's a sort of minor comment to pick out. I don't know what you thought.
Yeah, I think that's really astute. So, I mean, I don't want people to overinterpret discontinuation here. Discontinuation on the investigator's choice was higher, sure, but it's immunotherapy. And so we do have discontinuation rates when people run into those immune-mediated side effects. Let's recall that discontinuation due to targeted therapy in the 10% range is a surprisingly high number, right? And it's preferentially one drug over the other. So that tells you we think some of the side effects are driven more by one drug than the other. Compare this to the daraxonrasib data in pancreas cancer. So one of the conversations that I had at that thing I did on Monday evening, so these patients, so, you know, there's this former congressman in the US, and a month or 2 before ASCO, he did a New York Times interview, as well as a podcast or so, or maybe he has a podcast where he's on the drug, and he showed the extent of the rash that people develop. And it's not a rash, it's like a toxic epidermal exfoliation that's happening. And, you know, I asked the pancreas guy, I said, talk about toxicity. And he said, oh, you know what? These patients get a little bit of rash or whatever. And I said, you call that a rash? I sort of like taunted him from the audience. You call that a rash? I mean, it looks like your face has been hit with acid, right? Now, that's this one patient who decided to be very public about his side effects. And so it's going to require a bit of management of that. But what he said that I thought was really interesting is that pancreas cancer patients, metastatic pancreas cancer patients, are so symptomatic from their abdominal disease. They might be obstructed in the pancreas or the bile duct. They might be, you know, with tense abdomen or just like liver filling up with met, whatever it is. But generally, it's a biliary obstruction and things like that that cause the symptoms. As soon as they start taking this, within days, their symptoms feel better. So they could give two shits about a rash, right? Because they are feeling better. I want to make the point that I think it's the opposite in our uveal patients. So what he said is you actually struggle to get these patients to hold their drug to let this rash heal because they are feeling so good on the drug. Their abdominal symptoms are ameliorated. They are going to keep taking it. It's actually kind of the opposite in uveal melanoma. Very few, if any, uveal melanoma patients, metastatic, walk into the office symptomatic. The liver actually doesn't have a lot of nerves in the middle. It's around the edge, right? It's at the capsule. So if a patient has one or two M1A, B, or even C tumors, but they're socked in the middle of the liver, they're asymptomatic. Those aren't often at diagnosis, first line, causing obstruction, causing a lot of symptoms. Yet then they take these drugs and they start getting syncope, symptomatic peripheral swelling. Their rings don't fit, their shoes don't fit, their pants don't fit as well. They start getting a lot of nausea and this diarrhea. So now they have a drug where they didn't feel their cancer before, they feel the side effects of the drug, and compare and contrast that with the daraxonrasib, with what the pancreas experts are saying. So this discontinuation rate is mild on a clinical trial, and I think that's, great. I think in the real world, we are really going to struggle. You are going to struggle as the prescriber, and the patient's going to struggle to want to stay on a drug that is helping, has a finite maybe course of helping, but is so terribly symptomatic. So this actually screams for really good supportive measures from the outset. We need to make sure people have a real handle on this diarrhea, the peripheral edema, and the hypotension. And Marlena kind of mentioned it in her presentation. There's a run-in of darovasertib first. You make sure people are off their antihypertensives. You, from the start, you potentially prescribe them a loperamide or an antidiarrheal medication. You make sure they have peripheral edema medication, or you get ready to start managing that. You get ready with kind of type and screening them for blood transfusions because anemia is another thing that happens. And you just kind of get prepared for that. As the crizotinib gets added, you make sure you have close touch with the patient. And on a clinical trial, you do, because they come weekly for this first little bit. But in the real world, we probably want to make sure we don't just give them a month's supply and let them out. We want to make sure we have kind of weekly telephone calls with them, supportive measures, et cetera, et cetera. Was that too much on side effects?
No, I think it's an important point, and actually just what you've been talking about, we have quite a lot of this in kidney cancer as well with these combinations just when you start patients actually, and I actually had this conversation in clinic this morning because I was talking about lombantum and everolimus. It's very similar. We need to see each other quite a lot, monitor carefully. First few weeks we need to get the dose right. Now that might be a good place to stop, I think, because and just to give props and congratulations to the investigators. Fantastic, important moment in the disease, I would say. So fingers crossed for regulatory approval and access,
Yeah, we'll love to see that soon. So great. So we'll pick up some other abstracts soon. We'll stitch it together.
And you're going to press stop?
Yeah, I'll press stop here.
Okay, now we're doing hopefully a smooth transition in the video to talk about another ASCO abstract. What do you want to talk about next? The atom?
I was thinking maybe we should do Keynote 942 first. No?
We can. It's a phase 2 5-year update.
Let's do Adam then. That's fine.
Well, I mean, for sure, obviously, I think we can agree the main takeaway at ASCO this year was the uveal study. This will be practice changing, we hope. It looks like it has a positive signal, hopefully supports a filing. And then, kind of the next big phase 3 that I would argue that we saw was in Merkel cell, phase 3 ATOM trial, adjuvant avelumab versus, I think it was placebo controlled.
Correct.
Yeah. Okay. And so that, it's 100 patients, but it's phase 3 for this disease, which is nice. And maybe you want to just tell us the takeaway there, the bottom line?
Yeah, and primary endpoint relapse-free survival, and the hazard ratio for avelumab versus placebo was 0.61, with a wide confidence interval about 0.3 up to about 1.1, 1.2. So the P value for that was 0.013. They do quote another P value, which is stratified age adjusted, of 0.55, but actually it's sort of similarly broad confidence interval, and the P value's 0.075. And I guess you'd have to say, and I think we said this at the time, the shape of the curves, that, I mean, there's a fair amount of censoring by the looks of it. And actually, they don't say on this slide the median duration of follow-up, but the curves sort of come apart quite nicely at the beginning, but then it looks as you go further down the line, as it were, that they're coming back together again. And again, I think you and I said that when we saw it for the first time, if I'm not mistaken.
Yeah. One of the things we should mention is this was a study specifically for Merkel cell with lymph node involvement. So they were trying, it seems like, to enrich for the population of patients who may benefit from adjuvant. There have been 2 prior adjuvant trials, ADMEC-O, Jürgen Becker, and the European colleagues, and then the STAMP trial, ECOG Akron trial, originally envisioned and run by Brian Gassman, and then Jan Maynard presented the data the last year or so. And both of those were essentially negative for RFS. STAMP trial had a signal for DMFS potentially, but the question was there, maybe the population they enrolled was too big and too much low risk disease. So here they're doing the lymph node positive, maybe that's the right population, has the similar shape of the curve, comes apart and then comes back together. And in that case, maybe the duration of treatment's not long enough to, that once the treatment is stopped, you start seeing these recurrences, or maybe further enrichment for the right population, the population that really needs to be treated needs to come out. I think Shailander made the point when he presented this. It was Shailander Bhatia at University of Washington, Fred Hutch, and 8 other sites. So it was a 9-site, essentially, consortium trial, really bootstrapped by the patient care consortium that they have for Merkel cell. Incredible, 100-patient trial. And I think he made the point that there were deaths in patients without a Merkel relapse. It's slide 9 in his presentation. And that brings up the difficulty with some of these endpoints like recurrence-free survival or relapse-free survival, where survival is an event. So death is an event, even if it's from any cause. So, maybe another way to think about this might be time to progression, where statistically you could analyze patients who die from other reasons, but they don't count as your progression event. So he had at least a few of those deaths without Merkel cell relapse on the avelumab arm that is bringing the curve closer together over time, but quite a bit of censoring out at the end. It is to be noted, though, that the placebo arm seems to have no recurrences after year 2. I don't know what explains that, whether that's just not enough patients on that arm, lost to follow-up or what. But the short answer is, negative for RFS. He did do some of this stratification and age-adjusted. I couldn't quite follow it, but I believe, it's a valid analysis where if you do it in an exploratory fashion, and I like that he showed cumulative incidence curves rather than Kaplan-Meier for that, maybe the cumulative incidence of Merkel cell recurrence in an exploratory fashion where they did it stratified and age adjusted, maybe it is lower in the avelumab arm. But overall, I think the takeaway is this is essentially a negative study. So kind of the third anti-PD-1, PD-L1, this is the PD-L1 of those 3 studies that's negative for adjuvant therapy in the all-comer population, in this case with lymph node metastasis.
Do you think there's a sort of statistical way to put these 3 smallish, quote unquote, negative studies together or not? Because it slightly feels to me, it's a rare disease, obviously, and the efforts of the investigators are fantastic, laudable, actually. And I'm just wondering to myself, had there been a kind of one big trial, let's just say, whether or not it might have shown a signal. But I know there's a fair amount of heterogeneity here, to say the least. Go on.
Yeah, I mean, in the drugs and in the populations from trial to trial, but let's not forget the STAMP trial was fairly sizable. It was a few hundred patients. You know, it wasn't
Yeah.
just, I think it was like 300 or so. So yeah, good efforts,
So,
really good efforts. And I
so
think
what,
it tells there's something here. Just we have to probably we have to decide if it's more treatment, i.e. longer duration, or just treating everybody at relapse. You know, is the reason the curves come back together is that you relapse on placebo and then you get salvaged by avelumab in the metastatic setting. And so maybe it's a treat now versus treat later. Maybe we need to do a crossover. I don't know. I mean, I don't think we're done investigating this. I think we just need to think about what that trial design looks like. And I know really smart people are thinking about that.
yeah, I mean, it feels to me like there's a signal in there, right? And actually, most of the trials have sort of narrowly missed the primary endpoint, which then I guess brings up some interesting discussions in clinic as well. If you've got access, which is actually the very final bullet point, individualized decision making
Yeah.
regarding adjuvant therapy in clinical practice. I think that's
And
very fair, actually. Yeah, all
good.
agreed.
And now let's get to your favorite study you've been itching to discuss. This 5-year Keynote 942 update. This is the phase 2 trial of intismeran autogene plus pembro versus
Autogene.
pembrolizumab in high-risk resected melanoma, now published in JCO. Tell us about the authors and the trial design.
Why is it my favourite study?
Because you've been mentioning it a few times.
Oh, okay.
Can we talk
Yeah,
about
so
it?
yeah, we've heard this a few times now. Obviously, this study, Jeff Webber certainly presented the first data, I think, and maybe even the second readout from the study as well. But anyway, so Matt Carlino presented this at ASCO on the Monday morning session. Manuscripts in JCO, and just shout out, obviously, which I think is what you might have been driving at, obviously to Matt, but also to Adnan Katak, who was our fellow. I don't know how long ago now, probably quite a long time, maybe about 10 years. So it's great. It's obviously, makes me proud always to see Adnan as the lead author. Is there much to say about the study design or anything else that we don't know already? Probably not. What do you think?
So I want to say a couple of things. 2-to-1 randomization to vaccine plus pembro versus pembro in the resected stage 3 setting. The vaccine, just due to manufacturing, it's made either from the lymph node metastasis or the primary tumor, or in some cases they look for both. 34 neoantigens per patient, then turn into a vaccine with mRNA production. And then the vaccine, because of manufacturing, comes in at cycle 2, day 1 of pembro. This is pembro every 6 weeks. So it's 9 pembrolizumab infusions and 9 vaccine infusions, but the vaccine is given every 3 weeks starting at week 6, basically. So cycle 2, day 1. So no, the point was made when we first saw this survival curve, recurrence-free survival curve, is, they may look pretty similar in the first 6 to 12 weeks. And that's really because nothing is different between these two treatment arms in the first 6 weeks. Vaccine comes in at week 6. They're showing us the stuff in months. So it's going to be hard, the survival curves in months. So it's going to be hard to sort of really parse out where the 6-week mark is on that curve. But, previous publications, you can probably go see it. The other thing I want to mention is if you look at the demographics table, so this was a study for resected stage 3. If you look at the demographics, there are no stage 3B patients in this study.
Yeah.
And that's just a warning sign for me, because in this phase 2, stage 3 and up, no stage 3B. So this is a study of 3C and 3D and a limited number of stage 4s. But you and I both know that the phase 3 that has completed enrolling, that we're waiting for the readout of essentially a similar schema, vaccine plus pembro versus pembro alone, is for stage 2B and up, clinical stage 2B and up. And so what happens when you start enrolling 2B, 2C, 3A, and maybe some 3Bs, but maybe not if the study's a sort of a harbinger? When the previous study was in the 3Cs, 3Ds, and limited stage 4s. Are going to be comparable data sets, basically?
Yeah, I mean, I wonder if that's actually almost the most important point here to look out for. I mean, just to nail the numbers as well. So in percentages, pretty much 85% in both arms, just under 3C. 3D, 2 to 4%, 2 patients in each arm. And then stage 4 was sort of between 10 and 15%. So the vast bulk here is 3C. So I think all of those points are pretty well taken. And the other point, I think, obviously, is where neoadjuvant now fits into this. When we see the results of the phase 3, hopefully later in the year, it's going to be really interesting discussion to try and make sense of that in the clinic. Who might we be thinking about, if assuming the trial's positive and there's approval and access in due course? What's the group of patients we're going to be thinking about this in? So, I mean, I think that's definitely one to watch for the future, isn't it?
So anyway, I guess the takeaway at 5 years, though, unlike the previous study we were discussing, Adam, for Merkel cell, these curves remain separated. Good.
Yeah.
Not practice changing yet, not practice informing yet, because we don't have access to this. But as you say, when we do have access, where to place this in therapy may have slightly changed from when these studies were enrolling. So.
Yeah, and maybe for the future, particularly in terms of neoadjuvant, and this is the question for trial design, really, isn't it? How, assuming the phase 3 is in due course positive, how do we start thinking about incorporating this into neoadjuvant strategies? There's actually a load of interesting stuff in there to think about, I think.
Yeah, I mean, no shortage of people have gone to Moderna and Merck with the ideas. I mean, certainly the SWOG group, we approached them in 2023. I know Hussein Taubi and Georgina and Christian and everybody has gone to Moderna and Merck with trial designs. They've heard it, path non-responders. Maybe it's for, maybe this is for the neoadjuvant setting. Maybe it's just the adjuvant mop-up of the non-responders. Maybe it's adjuvant for everybody. Anyway, it'll be fun to discuss this if and when we see things mature. It may be on our horizon to see the phase 3 results soon. So stay tuned, everybody. What else at ASCO did we hear? We heard a couple of cool pilot studies for neoadjuvant therapy. What's your kind of high level takeaway? We heard Ipi-Nivo-Rela, and then we heard NeoReNi.
Yeah. So, I mean, in reverse order for me, I think NeoReNi, I mean, it's interesting really because they were presented right next to each other, and Jeff Sosman jumped straight up on the mic to talk about non-randomized studies. And I think Georgina Long actually defended the position quite well for the NeoReNi study, which is to say, then this is thick primaries. You stage them so that it's actually stage 2. Follow them up with dermoscopy, take some of the thick primary out, leave some in, treat with Nivo-Rela, and then look for response for the residual melanoma that's left in situ, and you're seeing high path response rates there in about 20 odd patients, I think, which are a mixture of 2A, 2B, and 2C. And in fact, quite a lot of the patients, I think from memory, around 10 or so were 2A actually. So for me, the clear thing that demonstrates, at least in the setting that Georgina and colleagues did this study, is the feasibility. And I think that's a pretty promising area for us as a community to think about for the future. Go on.
Cool, I agree. Cool. What about the Ipi-Nivo-Rela triplet with the one?
Yeah. Yeah, that's right. So again, it's 20 odd patients. I think Ahmed Tahini presented it, if I'm not mistaken. We know a bit about Ipi-Nivo-Rela already. We've talked about that before in terms of toxicity. And again, this was in stage 3, and we saw pretty high path response rates. And I think this is a little bit where Jeff Sosman was coming from, actually, but how do we really distinguish what we saw there? If you think about the confidence intervals for those response rates from what we know already from S1801 and Nadina. So that's one comment in terms of efficacy. And then I think in terms of toxicity, and this is probably really, there was one death from myocarditis. And what I think about this, and you're the expert and I'm not, is that actually, come on, stop that. some of these patients actually will do very well with single agent anti-PD-1 if you just think about the toxicity. And then obviously with ipi-nivo per Nadina, you're already seeing pretty high response rates and with some more toxicity. So I'm just thinking in a sort of, let's say an otherwise uncharacterized population. In other words, we don't know that they've got features, bad features or anything like that. Giving everybody upfront triple therapy actually, to be blunt, seems like pretty heavy going to me. And of course it's feasible in principle, right? Of course it is. We sort of know that already, I think. Go on.
Yeah. Well, I guess, and 2 comments, is it feasible when there's 1 death, or does that does that give us pause about the feasibility? Maybe that's more of a safety issue, but safety is part and parcel to me with feasibility.
Yeah.
Doing something safely are almost in the same breath. Of course, that patient had, it came out in the presentation, maybe that patient had some pre-existing autoimmunity. The other thing to mention is it was 1 dose of triplet, and then 4 weeks later, it was a NeoReNi dose. But even just with that, like that, how much of that is over treatment, to your point, where maybe single agent or a Nadina style regimen could have been sufficient. And maybe it's also worth mentioning in Georgina's NeoReNi trial, I think the non-responders went on to get NeoReNi in the adjuvant, so kind of a non-standard adjuvant, but all very nice to see these kind of creative, innovative trials, not compromising a ton of patients to ask a question, but meant to get us perhaps to a randomized trial or get us thinking about hypothesis generation. And I think both do accomplish that. Jeff was maybe overly critical about the number of patients that they put on these non-randomized, but look, in a 10-patient trial, you can always cherry pick your 10 favorite patients to make it look like they're, also there's some psychology that happens when you have a 10-patient trial. It's not just the first 10 patients who are eligible that walk through the door. You're a little more judicious about, we only have 10 spots, and, and it's just normal human behavior that will happen. 20 patients, a signal both for toxicity and possibly for efficacy may emerge a little bit. So I don't fault any of the studies for these non-randomized pilot. I actually like that they got drug company buy-in to do it. They were able to design it smartly. And here we are in 2026 seeing results. It didn't take 10 years because that's the whole point of the neoadjuvant platform, is it doesn't take a long time to read these things out. So I think it's kudos to those investigators. Where we go next, I think, is a podcast for another day.
Yeah, I agree with that. So is that everything, or did you want to talk about your favorite subject?
Yeah, I do think it's worth talking about another cool thing that came out of University of Washington, Fred Hutch, from the medical oncology side. And this was in the rapid oral section. You're smiling. Tell me.
No, because you actually haven't said what your favorite subject is yet. Carry on.
Well, I have lots of favorite subjects. I was a maths person, so maths is my favorite. I guess this kind of gets to that. But I liked this presentation by Hemant Kandalia. And Hemant, please reach out if I've pronounced your name wrong. I know I'm saying your first name right. I don't want anybody calling you Hemant. But I don't know if I'm saying your last name perfectly right. Kandalia. I think that's right. So, and it looks like he might be a medical oncologist or maybe a medical oncology fellow, because it says postdoctoral scholar, on response-focused analysis of the impact of circadian rhythm on efficacy of first-line immunotherapy in melanoma. That's a mouthful, but what this is, and it looks like Shailander Bhatia was the senior on this, so probably very well thought out if Shailander is involved, is there a time of day signal in terms of efficacy with first-line metastatic melanoma? And I don't know, did you click through these slides at all to sort of have a feeling on it? They did early before 1 p.m. infusions, late after 1 p.m., 216 patients, 78 patients got their infusion, and it's the first checkpoint inhibitor they looked at before 1 p.m., 138, so almost 2-to-1 separation there. Got their first ICI infusion after 1 p.m. And I think it was any type of first line non-adjuvant, so monotherapy combo, I'm sure they know who got mono and combo. Yeah, here it is in their demographics here. And ultimately, they didn't find anything. And if you look at their kind of objective response rate by time of day, they do it by every hour, and it's all over the place. So their conclusion, maybe you want to read off the conclusions?
Yeah. Early bird does not catch the worm. That's their conclusion in very big letters at the top of the slide.
Oh,
Yeah.
I totally missed that. Good
What?
job. Good job. I totally missed it.
No, I like the way they did it. They're using response rate, and of course it's a retrospective analysis and everything else. But I think they went about it in a pretty smart way, I have to say. And so, there's a few different data sets now, and there'll be more in the future. And I remain unconvinced as of now. And frankly, I've always been unconvinced, or skeptical is a better word. I haven't really seen anything to convince me that this is real at the moment. That's the bottom line for me.
Selfishly, I'm going to ask you to do a podcast on this paper that we have in press. It's been in press for over a month. I can't find it online, 2 months maybe. And it's, we looked at our phase 3 S1404 adjuvant Pembro versus adjuvant IPI study, investigator's choice, mostly IPI. And we looked at the Pembro only arm, about 600 patients. And because it's phase 3 registrational in SWOG, we have the time of infusion. We don't have it on our phase 2. So we don't have it for S1801 for everybody that's been asking, but we have it for S1404. We not only have the time of infusion, we have which arm the IV was started on. We have the time of every infusion and every laterality, everything like that. I mean, this is a joke, but maybe we need to start looking at left arm versus right arm. Maybe the arm that's closer to the sun or closer to the equator. I mean, this is kind of all that it's getting to. We looked and we couldn't find it. And so that's Journal of Oncology Practice. It should be coming out. Megan Othis is the first author because she really has a great handle on this kind of data. And at the time we do that podcast, perhaps we can take a look at this lung cancer Nature Medicine paper that's since had a letter, a note from the editor on the website saying it's.
And are we going to invite Megan?
We definitely should. We definitely should invite her.
I'd like to do that. Yeah. Again?
I said, Megan, if you're listening, please come join us.
Anyway, I'd love that.
Best of ASCO. What did we miss? I mean, there was obviously a great session on TIL therapy. There was an abstract on Anzicell, on OBX115, all incredible data. We're just not mentioning it here, just because it's kind of still preliminary. Most places aren't going to have access to this. Keep your eyes open for that, or what's the thing that you say? Watch this space.
Watch this space. Yeah, no. What did you say?
Nothing. I was doing my British accent.
No, I mean, I think we covered the main things. We touched on the main things, so there's some good stuff there. And I actually think the cellular therapy stuff looks really exciting, but as you say, relatively preliminary. But I'm sure we'll see more of that in the future.
Yeah. Good.
Watch this space.
Okay. So we'll do a quick fact check on this one and then get this one in turnaround quick for you guys. All right.
Thank you.
Take care.
Bye. You pressed stop, didn't you? Hi. This is fact check for the Best of ASMO ASCO :2026. I was getting confused then. And there were a couple of things we wanted to do, one of which was number of attendees, I think, at ASCO versus ESMO.
Which one's bigger?
Which is bigger. And then there was a thing about sort of simultaneous publications as well. So why don't you, as you're American, go first with ASCO attendees, and then I can compare with ESMO. How about that?
I mean, I'll tell you what my source is, which is maybe part of it. On LinkedIn, there was a nice ASCO, post from ASCO, and it was just people walking around McCormick. I think it was a shot of one or two of the plenaries, probably Brian Wolpin's daraxonrasib presentation. And, in there it says, we just had a great ASCO, blah, blah, blah. And it said 46,000 registrants. Recognizing that that's a combination of probably in-person, hybrid, and then virtual only. registrants, but 46,000. So that's the size, and that's kind of where I'd heard ASCO was, in the 40,000 range.
Yeah,
So
fantastic. So that gives you your
pretty good.
size. What about your breadth? Any comment on that?
Like how many continents and everything?
Yeah. I reckon continents, probably there'll be people there from every continent, right? With the likely exception of Antarctica, right? But the reason I ask, obviously, is that, so ESMO 25, I think, 37,000 participants, this says. Don't know yet for ESMO 2026, but from 174 countries and territories, which is a lot. Because I thought there, without wishing to do a fact check on a fact check, I thought there were only about 175 countries in the world. So the bigger question would be, which countries haven't sent someone to ESMO last year? Carry on.
181, maybe 184 countries in the world, something like that. Anyway, yes, we're not doing a fact check, but because we've had this conversation when the Olympics come around. You say how many countries are there in the world?
Yeah. So it sounds like at the time of writing, which is June 26, ASCO's winning on size, right? But then we'll have to just check the comment about breadth, I think. But we're not doing a fact check on that. We'll just leave that hanging there.
No.
And then
Go on. Well, do you want to make any comment about because the deadline for ESMO regular and late breaking submission, at least the placeholder for late breakings, has come through. Like, are you guys decreasing in your submissions, increasing? Well, first of all, why are you such an insider? Why are you ESMO Illuminati?
Illuminati. That word has a lot of baggage attached to it, actually. Anyway, so as you know, I'm the scientific co-chair for ESMO 26 with Yelena.
That's a massively big deal, right? Congrats.
I don't know. I mean, thank you.
No, come on. As a career highlight, did Martin ever chair ESMO, scientific co-chair of ESMO?
Not that I can remember.
When was the last time somebody from the Marsden was a co-chair of ESMO?
I think Johan de Bono, who is sort of ICR Marsden. Johan was around, I think it was 2013. Again, let's not do a fact check, but actually I can't remember which chat chair I was that year, either Skin or GU. I really can't remember. But actually Charlie Swanson, my friend, was one of the chat chairs that year as well. And I think Charlie was the last UK person to be ESMO scientific chair, which just was a couple of years ago. Paris 2022. I think we were both there for that one, weren't we, if I remember correctly?
Yes.
S1801 presentation for everybody else.
Okay. Finicky discussant, but
yeah,
the start of
that was me, by the way, as well, just for the record.
It was the start of our in-person friendship. We'd known each other on Zoom before that.
Yeah.
But, I liked your discussion, obviously. And then you were very kind and generous. You and Christian came to our S1801 celebration dinner. Very kind of you guys to do that. Anyway, the point is, track chair, scientific co-chair of ESMO is a tremendous honor. It really does mean that ESMO sees you as a really well-regarded voice here. And your institution hasn't had somebody do this for over a decade. So that's massively big. So I fully expect to see a Marsden purple banner in the exhibitor hall, just with you in a dunking booth. So everybody can go.
What's a dunking booth? I don't know what that means.
Where you sit on top of water. You sit on a platform on top of water. And then people throw a beanbag to try to hit a target.
Oh, like a kind of medieval sort of fair or something.
Carnival game. Yeah.
Oh, wow. Okay. And then the other thing you were asking about the abstracts is that, we just got the abstracts in and we have a record number of abstracts this year. So that's great news. I'm not sure I can say officially what it is, but it's a record number. So that's very exciting and plenty of work to look forward to over the next few months, which leaves the final bit, which was about simultaneous NEJM publications, I think, right?
It was NEJM, and I also have JCO here because, as the sort of companion journal for ASCO, or as the premier journal for ASCO, maybe it's important there. NEJM, and to be fair, during ASCO, during the week of ASCO, I didn't log on to nejm.org. So, sometimes during that week of a conference, they really promote it on their website. I didn't log on, and I can't find any sort of fingerprint of that. In fact, the last really good NEJM ASCO page that I can find is from 2019. It's actually nejm.org/ASCO 2019, I think, is the page. I don't see that they've really dedicated much since then, which is a little strange, but this is what I see. I see 6 NEJM simultaneous publications. And actually, at one point, I had them all saved here because I thought it might be nice to tell you what they were, but apparently I didn't save it. Let's see if this does it. Yeah, this isn't really going to do it, but it's obviously the daraxonrasib was a big one. There was a myeloma publication, I believe. There was a lung cancer one, maybe even from a drug that's not even available, which is sort of the big controversy. And then for JCO, there were 10 simultaneous in JCO and 6 in JCO oncology practice. And so that's not too shabby. And obviously JCO was proud to have those simultaneous publications. I think intismeran autogene was one.
Yeah.
So that might have been our only melanoma simultaneous, but so yeah, that's the number of simultaneous publications. And what do you forecast? Why don't you make a prediction here? How many simultaneous NEJM at ESMO, and how many Annals of Oncology simultaneous publications? Let's make a prediction. You have a position of insight here that would be cool.
Zero insight, actually, because
no, you haven't looked at any of the submissions.
No, of course I haven't. And even if I had, I am sworn to secrecy. I'm gonna say 4 NEJM, 6 Annals of Oncology.
Okay, we're gonna do this like a game show. I think it's gonna be 10 NEJM. How many did you say Annals?
6.
You think 4 and 6. You think with record-breaking abstract submissions, ESMO is going to have 10 simultaneous publications in these high-impact journals.
Yeah.
Okay.
And I'm hoping to be wrong. I'm being conservative.
Yeah, but you're being conservative. And what happens when, as a scientific co-chair, you're so lowly wrong with your estimate?
I don't know, I get sacked.
What do I get? No. Your term ends. Basically, you have to hand the throne over. I think ESMO simultaneous publications, Annals, is going to be, I'm going to say 15, 12 to 15.
Okay.
So smaller meeting, but I think they're going to come out with more publishable material.
Yeah,
we can unpick that another day.
We don't know at the moment. It's going to be a smaller meeting. I think we need to wait and see.
Oh.
Actually.
Okay. Well, this is a fun fact check. I hope everybody has enjoyed our Best of ASCO episode. Obviously, we couldn't talk about it all, but we hope we gave you something. So, thanks, James.
Very good. Bye.
Bye.